Like she said, we work over at Summit Rehab, and we do work with a lot of individuals who do have Parkinson's, and of course a host of other different conditions as well. But one of the things that that kind of led us into doing this particular topic as well is that we do a lot of work injuries. We work with a lot of people who get hurt on the job, and we see the gamut of pretty much every type of job you can think of. But one of the top occupations that we see people from are caregivers, whether that's in a facility, and I'm going to move this over here so I can stand a little more to the side, but whether that's in a, say a skilled nursing facility, or even just caregivers that are working in their home with a family member or a client. So to us, it's really important to teach people how to move appropriately so that we don't see them, ultimately, because a lot of people do get hurt just trying to assist other people and just trying to help out. So we want to just share a few things about that and how to try to stay healthy yourself as you're going through these different processes, and maybe a few tips and tricks to be able to assist your family member or your client in moving a little bit better. So first, I just want to share a few facts with you about caregivers. And these are from the National Family Caregivers Association that I got actually from the National Parkinsons Association. They had all these statistics in their resources. But half of the population in the United States has a chronic health condition. So that's a lot of people that have a condition that is not just a, hey, I hurt my back, I got better and I'm good, but have a condition that sticks with them. And 41 million people have health problems that limit their ability to independently perform activities of daily living. So, those are things like brushing your hair, brushing your teeth, eating, all those kinds of things. 41 million people have problems that affect their ability to do that. So that's a lot of people that need assistance. And currently, there's an estimated 25 million caregivers in the United States. So that's a lot of people that are helping out. And only 25% of Americans who require long-term care receive it in an institution. So we're talking like a skilled nursing facility. So 80%, a good portion of those rest of those people are getting that at home, are getting that help at home. And 80% of home care is provided by family.
Excuse me, Caleb, one
Yes.
moment. Could I remind all our sites to keep your microphones muted until we get to the question and answer section at the end? Thank you very much.
All right. So 80% of home care is provided by family. So, many people are kind of thrust into that just due to the relationships and whatnot. And so oftentimes there's not training that goes with that. I think they're dealing something with the sound real quick. Hold on a moment.
Sorry, this is Richland. We're trying to audio dial in because we can't get video.
Consider this a commercial. We don't have anything to sell, though, although these are great penguins.
Richland is our newest location.
Excellent.
So they're working on their.
Good deal. We're glad to have Richland. Glad you could join us. So, again, 80% of home care is provided by family members. So many of those are then unpaid family caregivers. And so they did an estimation of how much money would go out if we were to pay those people the prevailing wage. And there's approximately $194 billion a year would go to family caregivers. That's a lot of money. And that's a lot of time that quite frankly, you are putting in that you're not getting paid for. And we do it because we love the people that we're working with. But it's a significant amount of time, and it's a very large commitment. And so, of course, we're thankful for those people who are willing to sacrifice and put in that time. Now, 3/4 of all caregivers are women, and many are what we call heavy-duty caregivers. So a heavy-duty caregiver does more than 20 hours a week. And many of these heavy-duty caregivers don't get any outside help. So many are there full-time and don't get any assistance. So they don't get a day off. They don't get to take a sick day. You're on every day. And so once again, very thankful for those people, but it's a very demanding job. So a little of my personal connection with caregiving. I actually worked as a caregiver in college, my first year of college, and I at that point in time had no interest in physical therapy, had never had any experience as a caregiver, but a friend of my brother's was doing it and said, hey, here's a job for you. So I went and worked there for a quarter or two while I was in college, and I was horrible at it. It was a very tough job, and there were so many things that I didn't know how to do. But I was thrust in the middle of this situation, taking care of a wonderful gentleman, but his needs outweighed my personal skills, and I ended up quitting that job after several months, because quite frankly I didn't have the abilities to do it well, and that's what happens many times to people. They get thrust into a situation. I've got a cousin who is my age. He's actually just almost a year older than me, with severe autism. And so I have my aunt and uncle now, just my uncle. My aunt passed away, but he's the primary caregiver, 24/7. He's on the job, and so again, he's one of those heavy-duty caregivers that doesn't get a break, that doesn't get to take time off. And then most recently, my wife's grandma was diagnosed with ALS, and approximately a year ago. And the changes that she has undergone have been difficult. And her daughter Cheryl, that's them pictured there. You can see that's Betty Comstock, and then her daughter Cheryl. Cheryl has become the primary caregiver. And in the last 1 to 2 years, Grandma's had a dramatic loss in function. There's just a lot of things that she can't do anymore. She essentially went from just having some weakness in her legs and maybe having a little bit of difficulty getting up and out of a chair to having serious difficulties with trunk control, being able to sit up, being able to control what her head does, and even just maintaining an upright posture, let alone being able to move and to transfer or anything like that. So in this last year or two, my wife's aunt has gone from a daughter to suddenly full-time heavy-duty caregiver, and has had to adapt. Betty's husband died in the last year, and so that was a difficult process. Cheryl's had to deal with all the financial issues, has had to coordinate all of Grandma's medical care, planning for disease progression. She's just recently moved to a new facility, and that old facility, which was a great facility that her and her husband could both be at, unfortunately the caregivers there were not well trained as far as taking care of someone that involved. So part of what she had to do was even educate the people who were working with her mother to be able to just live on a daily basis. And so again, there's no course on that for that she had. It was Caregiver 101 on the job training of learning how to adapt. And I know that's been the experience for many of you, maybe picking up bits and pieces here, but you learn how to do it as you go, and that goes both for the caregiver and the family member. We have to learn, and we have to learn how to work together and adapt. So just a couple words on a new diagnosis. There may be people here who have just recently been diagnosed with Parkinson's disease or really any other neurological condition. And there's a lot of emotions that go along with that, both for the caregiver and for the patient that's been diagnosed. And I'm sure many of you could come and tell me all about the different steps and the process that you had to go through to be able to kind of come to terms with that diagnosis. And there's many issues related to role and responsibility. Those things change, especially in those first few years, the transition, and it can be a difficult one. And so a couple of just quick tips. Begin planning ahead if you do have a new diagnosis. Start thinking ahead of how as things progress, how you can can kind of work with the caregiver, or if you're the caregiver, work with your loved one or client into that transition, because it's much easier to deal with something if you've planned ahead than to be surprised and just thrown into the mix all at once. And that's part of what we're here today, is to try to give you some tips on physically helping that individual. There's plenty of community resources out there too. I know here in Spokane, there's some great opportunities. Parkinson's Resource Center, who's hosting our presentation today, has a lot of excellent things that they do in our community for Parkinson's. And one of the things they offer are support groups. And I highly recommend that you take part in those, both as caregivers and as individuals, because it can be really helpful as you make those transitions. Community centers offer many things, and if you're not in a town that has, say, the Parkinson's Resource Center, still search around, look around, and see what kind of community resources are available, and then continue to live your life. Many changes in the management of Parkinson's have come along in recent years, and the neurologist could tell you a whole lot more about that as far as medications are concerned. But we're seeing people with long-term diagnoses that are still very active and out playing tennis with, say, a 30, 40-year diagnosis history. So things are changing, and there's a lot of really neat stuff happening in the world of Parkinson's. So if you have a new diagnosis, continue to live your life, enjoy it. You might have to make some modifications, but there's a lot of really great things that are happening in the world of Parkinson's. And then, of course, a bit of a shameless plug. We are therapists, and utilizing therapy services can, at various points in time, be really beneficial. Whether it's caregiver training, whether it's learning how to perform different activities that are becoming difficult in a more efficient way, learning to stay physically active, maintain your conditioning, all those kinds of things have been shown by research to be really beneficial. And so we really do want to help out and assist in whatever way we can. And typically what we'll do is we'll see someone for a short period of time, give them some things to work on, and send them out for a while and let you work at home, and then address things as they come up. So oftentimes with just a little bit of a check-in, we can assist with a lot of different aspects of life. So as far as caregivers go, some of the challenges that are faced by caregivers, a lack of freedom, especially for those who are under the heavy duty listing where there's many hours a week. May limit your participation in jobs, hobbies, personal life, religion, volunteer work. All those things are affected, again, both for patient and for caregiver. Criticism from friends and family. Everybody's an expert on everything, really, but everybody wants to tell you how you should do your caregiving and what you should do, and how they would do it better. And so that is a legitimate difficulty that caregivers face. Certainly it's physically and emotionally demanding, and financially too. Certainly if you are family members, you're both affected by the financial things that happen. And even if not, a lot of times, we feel duty bound to assist financially, and so there's a lot of things that go into that as well. So caregivers really do encounter a lot of stress and certainly a lot of physical things that can make their job difficult. So a few basic guidelines, and then we're going to move into, again, the physical assistance part of our presentation. But one that oftentimes we don't think about, and this is just for people in general, is nutrition. Getting a balanced diet. We don't think about that much, but it makes a huge difference as far as your energy, as far as your ability to manage stress, and as far as your ability to really provide the best care that you can. So certainly getting all your fruits and vegetables and staying hydrated. And hydration is something we don't really think about. A lot of us really live in dehydration, and I fit into that category. I'll go through a whole morning of working with patients and realize I haven't even had any water yet today, and I'll do the afternoon and maybe I'll get a glass or two. But, that is, and I'm someone who's supposed to know about those things. So a lot of us just kind of live without really paying attention to some of those nutritional factors that really can make a difference. And just kind of as a side note, with consumption of water, if you want to do it the complicated way, you can take half your body weight and instead of going pounds, call that ounces. And if you take 2/3 of that and drink that many ounces of water a day, and then a third of that can be coffee or every other beverages. That's the way you figure it out. Or if you're lazy like me, drink eight glasses of water every 8 hours. You can do that too. That's a whole lot easier. So, but it is important to stay up on your nutrition, up on your hydration, both for patient and for caregiver. Sleep. Sleep's a big deal, and we know that Parkinson's can really affect your sleep and really impair that. And so both for patients and for caregivers, it's so important to maximize the sleep that you're able to get. The CDC recommends 7 to 8 hours, and I look at that number and laugh a little bit, because once again, I have a 2 and a 4-year-old, and my 4-year-old likes to get up at 5 o'clock in the morning if we'll let him, and my 2-year-old likes to stay up late. So there you go. But again, sleep is so important for us to be able to make good decisions, to be at our best, to make the appropriate choices when we're assisting others. And then exercise. Again, the CDC recommends 2.5 hours of moderate intensity aerobic activity every week, and also recommends some muscle strengthening. How many of you get that? And I have to put my hand down because I don't always do that. So some of you are even showing me up. But important, again, to stay healthy and take care of yourself as a caregiver so that you can take the best care of your loved one as well. And many of these things you can do together, and that, of course, is the best way to do it. Some other things to look at, some guidelines, emotional support. Again, look for those support groups and other resources in your area. A lot of times it's easy to think you're stuck in this thing alone, and you're not. There's many other people that can give you many helpful guidelines. I know that's something my wife's aunt really struggled with, was feeling isolated and not necessarily having a lot of information to go on. And there are resources around you, so take advantage of those. And then physical safety. So especially as we progress through the Parkinson's diagnosis or any other diagnosis that is progressive in nature, we start having to do more things physically, whether it's just doing more of the chores around the house or whether it's starting to physically assist our loved one or client as we're helping out with daily activities. And so that's a piece that is definitely important. And so with that, again, you want to learn proper technique for assisting. That so much of it is in technique and in how you assist that person. And that's how you avoid injuring yourself. Because ultimately, if you're injured, who is going to step up and be there to help? And it's so something that we definitely want to take note of. And then again, there's community resources for transportation. I know here in Spokane, we've got the STA, but there's also a paratransit system that you can apply for that helps with, if you're having more trouble getting around, those resources can be really beneficial. So safe transfers, we're going to be talking about that a fair bit today. And safe transfers start with a safe setup. That's half the battle right there, is getting your area that you're going to be doing this transfer or this movement in set up. And so some of the things to do for that is look at both the surface you're leaving and the surface that you're coming to, and set them up for safety. Of course, brakes on wheelchairs, move armrests and footrests, other obstacles. Make sure that you're in good proximity to that surface you're transferring to. If you're too close, it's going to be difficult. However, we don't want to transfer across empty space either. So you have to do your best to set those things up because it's very difficult once you begin a movement to make that change. If you haven't set your feet up right, if you haven't created an environment that's conducive to that movement, it's pretty hard once you're halfway through to address those issues. So always look at it. Make sure you have everything where you want it before you make a movement. And then a lot of it has to do with the body mechanics, not only of the person performing the transfer, assisting with the transfer, but also for you if you're the patient as well. So a lot of it has to do with bringing yourself forward. Many of you have probably heard the toes over your nose adage, and I like to say chest over toes personally, but whichever way you look at it, it's using your center of mass, putting it in the right place so that you can use your body to make that movement as opposed to having to go against gravity in everything that you're doing. And then, of course, for the caregiver side of things, one of the things that we'll really emphasize is you don't want to lift, you want to weight shift. Okay, and that's a very important distinction. As caregivers, as those assisting with transfers, we never want to lift someone. Okay, there's ways to use leverage and body mechanics so that you're not performing that lift. And then, of course, protecting yourself with good technique. If you're not able to do that physically, then it's time to look for some help, so that someone that is able to do that is able to assist. And so that's something, again, a therapist or someone along those lines can be helpful in making those decisions, because once you're unable to do it, it doesn't help you at all to just get hurt at the same time. And it's not beneficial for that loved one as well. So, there does come a time where sometimes we have to seek a little outside help as well. So we've got some transfer no-nos. Okay, and again, I have a 2- and a 4-year-old, so I know about no-nos, and I'm going to share a few of those with you today. And then Melissa's going to go through some of the specific techniques that we just wanted to share with you. So one of the things that we actually see a fair bit is we're working with healthcare providers, and this is at all levels of healthcare, whether it be caretakers or nurses or many different people. Mechanics-wise, many people try to use this type of a transfer. Now, I know the picture's a little blurry, but you can see the person in the wheelchair has their arms up and around the neck of the person that's helping them out. And then in that second picture, you can see the individual who is assisting has lifted that person up from a bent over position. They've pulled that patient up while the arms are still around the neck. And then as they move to the chair, setting down in the same method. The problem with that is that, for one, it requires you to expend a lot from your back and lift and expend a lot of energy and put a lot of compression on your spine. But also, if there is any type of a problem and you begin to fall, if that patient begins to fall, the natural instinct is to pull your arms like this. And we see so many people with neck injuries because, it's a transfer gone wrong and a fall, and that pull on your neck can be a lot of force. And so, again, this is a transfer no-no, but we see it fairly frequently in ways that people tend to set up. This is just kind of another picture, but you can see in the pictures they're setting up, the caregiver is doing better, at least having their hands down low to make the transfer. But there's still those arms around the neck, which, again, if there's any problem, it's a very likely injury in that situation. And then another thing that we see from a lot of people is when they go to assist someone, grabbing by the arm or the shoulder to help assist that person to standing. And it looks nice. The arm is there. It's easy to grab. It's easy to utilize. The problem is that our shoulders are such a dynamic joint. They're made to move in so many different directions, which is good. We like that. The problem is, if something is made to move in many directions, there's less stability there. And as we age, we become even more sensitive to things that are happening in that shoulder. And so it's very easy to injure someone by assisting from the shoulder, by pulling from the shoulder, whether it's irritating some of the musculature system around there, or you can, with certain conditions, even dislocate the shoulder. And so this is something that we want to be aware of. There's ways of assisting that don't put that type of pressure on that joint. And so, again, it's about helping in a way that is both good for the patient, the loved one, and that is also going to be best for the caregiver. So a few things that we're going to look at. We're going to look at going from laying down to sitting. We're going to look at going from sitting to standing, scooting in a chair, moving from one surface to another. Then a few tips on just helping with walking, and then a note on just pressure relief for those who are confined to a wheelchair or something along those lines. And so Melissa's going to be kind of going through a few of these, and we have pictures for these. One of the things that I do want to say is what we're hoping to do is convey some helpful tips and tricks. However, if you're someone who is doing a lot of lifting and a lot of assistance, physical assistance, we do recommend getting a little bit more in-depth training, because it is difficult to master these techniques in just a quick slide presentation. So we want to give you some good information to go from. But again, if this is something that you're doing day in and day out, especially if you're starting to have pain, contact someone or come to our caregiver training that we're going to talk about later. And that is a free event. It's through the Parkinson's Resource Center, and we just want to see people transferring better so they don't have to come and see us. So Melissa's going to share a little bit more about some of those techniques.
Okay, so I'm Melissa, and I worked for 3 years actually here at St. Luke's doing a lot of transfers on very heavy patients who needed a lot of help and patients who needed very little help. So I'll try to do my best to give ideas with all the different levels, but as a general rule, having your loved one or the patient do it as much as they can is good for all parties. Number one, then the patient is maintaining their muscular activity. They feel like, hey, I was able to do something, and the caregiver isn't breaking their back for something that the patient can do. So we'll start with going from lying on your back to sitting. So break it down into a couple different motions. Don't worry about having to just pop right up like a daisy and be on your way. If you start on your back and have your knees bent up, allowing your knees then to roll over to the side and reaching with an arm, you're going to roll over pretty darn easily and probably don't need much assistance for that. Make sure that there's enough room between where you are and the edge of your bed. And a quick guide to that is if you put your elbow out at the side and your elbow's still on the bed, you'll have room to roll over. If the bed ends here and your elbow's hanging off the edge, you don't have enough room. So here's the rolled over position. The knees are still bent up. The arm is reached over to the side. And then from here, what you would do is push down through that bottom elbow and giving these verbal cues to the patient if need be, pushing down through that bottom elbow and that top arm while you kind of push your feet off to the side. It's hard to see in this picture, but with those feet going down, they're going to kind of help, like a teeter-totter, bring that body up. And so it's a nice way to really use your weight rather than a whole lot of energy to get the work done. So next is, if assistance is needed, that's right, where to put your hands. So if you do need to help out this patient, it's tempting to, again, grab an arm or something like that. But the easiest points of assistance to provide is going to be at your hip and at like a shoulder blade. So in this picture, you would have, and I'll kind of just come do it, you'd have one hand kind of under the shoulder, one hand here at the hip, and you would just kind of help them up that way. And that way it's very little work for the caregiver. The patient's able to help out. You're not impeding from any sort of assistance that the patient's able to provide. And the work gets done pretty darn easily on both levels. So the next one is going to be going from sitting to standing. So it's very tempting for people to want to grab onto a walker if there's an assistive device in front of you. They want to grab on and pull up. And oftentimes you'll see caregivers just, I'll hold the walker down. You go ahead and you pull yourself up to stand. Well, that is a very dangerous method to go from sitting to standing. And so if it's an armed chair, pushing up, I guess we don't have it at that one, but pushing up from the armrest, pushing up from the seat of the chair, primarily making sure that your weight is forward. If you're sitting up tall, it's going to be really hard to lift all of your weight straight up because all your weight is still sitting through your buns. So if you can bring your weight forward to where there's some of the weight in your feet, now the buns have been cleared a little bit and you can just push through your feet and stand up much more easily. And that's a cue that's very common that is necessary in caregiving. Lean forward. There's a high fear of falling, specifically falling forward. But if your feet are out in front of you and you're leaning forward, you should have a fair amount of room to go before there's any real risk of that fall. So getting the weight through your feet before you go to stand up. Yes, so Caleb just reminded me. Also looking at the foot placement, you want to make sure that your feet are under your knees, not way out in front of you, because then as soon as you try to get weight through your feet, you're going to end up pushing yourself back into chair. I'll grab this seat and kind of demonstrate if people can see me. Where should I be so that I'm right here?
Through there.
Okay. So if I'm sitting in this chair and my feet are way out here, I can lean forward all I want and my weight's not going through my feet. Can you see this okay? Okay. So if you bring your feet underneath your knees and then lean forward, now all the weight's in my feet and I can lift my buns pretty easy. But as I was mentioning before, if I'm sitting straight up, it's darn hard to try to come up here. So just getting that little bit of a weight shift forward and you can pop your buns up pretty darn easily. Okay? The other thing to think about, again, a safe setup. If I'm way back here, it's hard to stand up. I can't stand up from here. But getting your buns scooted all the way toward the edge, now you have extra clearance for those thighs to actually help you lift. So getting that nice setup where you're at the edge of the chair, feet are under your knees, and your weight is shifted forward before you push to stand. Then you're using your energy efficiently, and you're actually making the energy work. So here's a demonstration, a picture of being nice and forward, pushing down with the arms so that the arms can help if it's available. And then still staying forward through that stand. The other thing that's very common to be seen is, well, my buns are up, and now I feel like I'm going to fall forward, so I'm going to bring my shoulders back. Well, then you are going to fall. You're just going to fall backwards. And yes, there's a chair there. Hopefully it's still there, right? So coming forward, staying forward until you can get those legs straightened out and you're set, ready to go, okay?
And something, I'm going to just chime in here, something that can be really helpful is as you're performing that movement, if you think about squeezing in your bottom, squeezing that muscle back there, and then pushing through your legs, that can help focus a lot of the energy down through your legs and make it less about reaching forward and pulling myself up, but I'm actually pushing down. I'm using my glutes. Those are the biggest muscle you have. So if you turn those things on, they're going to be the best muscle to push you into a standing position.
Thank you. Okay, so if there is a patient that needs more assistance, that absolutely does need that hands-on help to get up out of a chair, here's a demonstration of hand placement and technique. So number one, again, you see the one hand placement is on the shoulder blades. It's hard to see in this picture. It's not actually underneath the armpits. It's at the shoulder blades here. Okay, because again, if you're at the armpits, now there's those shoulders come into play, which number one, they move around a lot. So if they're not stable, then what the heck are you holding on to? And number two, then there's that fear of injury. So being at the shoulder blades here so that as you go to stand up, number one, you're bringing them forward, right? As I pull back, he's popping up right there. So you have a decent grip on the body, and it also helps with that direction of motion. The other thing, I don't know if you noticed when I was doing that, it's really hard to lift up if you're holding onto the shoulder blades. So it's kind of a nice little check and balance that if I'm on the shoulder blades, I'm not going to be lifting. I really, truly am going to weight shift to help with that forward motion. Second point of contact if need be, and this is great for scooting forward as well as sitting that first one. The scooting forward in the chair, though, if that's needed for help, scooting one hand back around the hip, okay? Weight shift off whatever you're trying to move. So if you're trying to scoot that right hip forward, get off that right hip. Why are you moving all their weight? So weight shift towards the left side and then move that right hip forward. And that's what we're demonstrating in this second picture here. All of his weight's on the left side, and then you can easily scoot that right hip forward. And then you can weight shift to the other side and scoot the other hip forward if that much assistance is required for scooting in the chair to prepare to stand. Okay. So this would be with a patient who again needs a whole lot of assistance for moving from one surface to another. This is a squat pivot transfer. So looking at the body mechanics of the caregiver, you want to make sure that you can have a straight back okay, that you have your legs in a wide base of support, because if it's a tiny base of support, you go to lift somebody, you lose your balance, you're both going down. So a nice wide base of support with any of the transfers. And then also good hand placement. He has a gait belt on in this picture, so I don't know if anybody is using a gait belt, but they can be really helpful for a good place to hold on. Otherwise, if there's pretty structured pants, a pair of jeans, trousers, something like that, you can grab onto the waist or a belt within those pants as well. So we'll talk about the setup real quick. You notice the proximity. We're moving to a mat table right there, so we're switching surfaces. The chair is nice and close. Okay, his arm is out to the side, leading where he's going to be headed. His weight is forward. It's off of his buns, so he's ready to go. One thing that could have changed here is the armrest. If we got the armrest out of the way, he doesn't have to lift up quite as high, but we decided let's make him work a little bit and jump over that armrest. So wide base of support, good hand placement, close to our new surface, weight shifted forward, okay? And then the next picture, I think, shows mid-transfer. Notice he hasn't been lifted. I've just weight shifted back. So I am not doing any lifting of him at all. I'm quite simply holding on and moving to my back foot, okay? And that takes all of his weight and puts it into his feet. And then the next picture is just kind of the landing there. So again, I'm controlling his weight with where I am in my feet. Okay, if I'm forward, his weight's down on his buns, and if I'm back, his weight's through his feet. So utilizing that type of technique more so than a lift. Okay. So with walking, it's really tempting when you want to help somebody with walking, again, to grab the elbow or to grab the arm. How nice is it to just walk down the street kind of with your arm around somebody, right? So if you are using a gait belt, you can have your hand on the gait belt. Underhand grip is ideal because then you have some big muscles that if there is a loss of balance, you have some bigger muscles that can catch you. Whereas if you do this grip, under, the overhand grip, these are little guys, and they're not going to be able to help very much, and you're going to end up with an injury to your wrist or forearm. So an underhand grip, and then you can actually use the muscles all together. Let's see, what else does this picture show? Crossing across the body, you have a little bit more control, a little bit more stability for the patient. If there's a loss of balance one way, you can pull them into you. If there's a loss of balance the other way, they are actually coming into you. So that way you have a little bit more control of both directions. Pressure relief. So here's the demonstration of somebody who is wheelchair bound. A way to just get pressure off so that we're decreasing the risk of any sort of skin ulcers, anything like that. And it's an independent technique, so caregivers would verbally, for the most part, be saying, hey, don't forget it's time for your pressure relief, and not having to do a whole lot. Quite literally, just lean into the other side of the chair, okay? Suggested is about 2 minutes for every half hour if somebody is insensate or doesn't have good sensation of the area, or also if there's poor communication or nonverbal where somebody can't say, gosh, I'm getting kind of sore, I need to move around. So about every half hour for about 2 minutes if there is that communication or sensation issue. Otherwise, every 2 hours, making sure that there is a change of position to ensure that there's not going to be skin breakdown or any sort of pressure ulcers building. Okay?
All right, so I'll hop back in here and just share a couple of things. Again, like I said, if you are someone who is doing these things on a regular basis and having to exert a lot of having to give a lot of assistance, do recommend that you get some training, because it's one thing to hear and to see a picture of something, but we can't always tell what we're actually doing. And so getting someone who can watch you and give you some tips and some tricks to say, you know what, let's keep your back a little more straight there. Let's work on the weight shift as opposed to a lift. Some of those things are just ways that another set of eyes can really help you hone your technique and make it such that you can really maximize your efficiency and really be safe as possible with that. So along those lines, as I mentioned, we are doing an upcoming training event at our Valley location. We have a couple locations, but we're doing this at our Valley location, which is over on Argonne, and that's May 20th, and we're going to be doing it 12:30 to 1:30. And so for more information on that, if you want more info, you can check out the Parkinson's resource page, the Spokane Parkinson's resource page, or you can go to our website as well, summitrehab.org. And we've got our web team working on getting that information up, so it may be a day or two before it's there. But we'd love to have anybody who wants to come out and get a little bit of assistance on technique, whether you're giving a lot of assist or whether it's even just how to do better verbal cues to help each other be able to move better. That's all stuff that we can try to help you out with. We do ask, if you can, to try to let Cindy know so we know how many people are coming. That'll just help us make sure we have enough therapists there to be able to help everybody. So we may bring some from our other office if we need to. Excuse me. So again, that's May 20, and you can go to our website or the Spokane Parkinson's website as well for more information on that. Back to my wife's Aunt Cheryl, because when I was talking to her, she just had all kinds of things that she just said, I wish people knew, I wish I knew this as I was getting into this whole scenario. So kind of to close up, I want to give you some of Aunt Cheryl's helpful hints, okay? And one of the things that she has found so important is just communication, asking questions, and when you ask a question, listen for an answer. Because oftentimes, you know, those who are patients know that sometimes you're in a position that hurts. You're in a situation that needs to be changed, and you may not be able to fix it yourself, especially if you require a little more assistance. And then certainly if someone is having difficulty verbalizing, being able to work on that communication and understanding, whether it's using pictures or whether it's using print that's large enough that someone can see. Find ways to communicate, because that's the most important thing. She found with her mom that oftentimes she was in a lot of pain and nobody ever asked her, and so she never told, because you know she wants to be tough and she wants to you know, not be a burden on someone else. So be sure and ask, be sure and communicate. And certainly address pain. If there's areas that are building up pressure, you know, she used a lot of kind of the fleece blankets and whatnot to pad different areas. Just little things like that are ways that you can help address some of those issues, especially as someone is a little more advanced. And then she mentioned pictures and other forms of communication can be helpful. And then just keeping in contact with family, keeping everybody updated. Family usually really does want to be involved. They just don't know how. And so for her, for Cheryl, that was a big deal, and something that as she's been able to do that, has been able to get a lot of support from the rest of the family who isn't able to be there on a daily basis. So that's essentially what we have to present for you today. So we're happy to open up the floor for a bit for any questions or comments, anything along those lines.
You made it the whole way through without coughing, just right till the end. You
I
did
know.
great. Good job. Okay, so our sites, we're having a few communication problems in our connected sites. So I am going to go down the list of who I have checked off. Please unmute your mics and let us know how many people are there today. And if you have any questions at that time, let us know. If I miss somebody, just hop in at the end and we'll make sure we get to everybody that's logged in. Let's start with Anchorage, Alaska.
We have 4 present.
Thank you for being there today. Did you have any questions today?
Any questions? Looks like no questions. Thank you.
Okay. If you think of anything, as per usual with our programs, if you think of questions, because it's sometimes hard on the spot, you can always email or call me, and we'll get the answers if we can, or get you to the right place, which would be with Caleb and Melissa. So, Billings, Montana. I hear him. And if I go too fast, still just let me know that you're there. Coeur d'Alene, Kootenai Medical Center.
Yes, we're here. There's only 2 of us here today.
You know, it's beautiful out. Everybody decided.
It is beautiful.
And do you have any questions today?
No, we don't. Thank you.
Okay. Colfax. Colville, Providence, Mount Carmel. Lewiston, Idaho. Too quiet today. They're not marked, but Miles City, Montana.
This is Miles City. We have 12 people here and 1 dog.
Yay!
And this is not really a question, but a comment.
Okay.
That is that I have experienced this, and other people have too. If you have a husband and wife, if the husband is the patient, the wife can pretty much carry on with what she was doing in addition to the care side of it. If the wife is the patient, the husband has to learn a whole lot of things that the wife did, like cooking and stuff like that. I've had to do that, and one other man here has had to do it also.
That's actually a really good point. That's part of that thinking ahead after the diagnosis is, that, hey, I guess one of us, the other one's going to have to learn how to cook and do some things.
And shop and everything else, yeah.
Oh, yeah. And that's where a lot of those...
laundry.
And that's where a lot of those support groups really come in handy, because there's a lot of things as men especially that goes into that, and so that's that whole change in roles that can be very difficult. So definitely talk to other people. If you find yourself in that situation, talk to others that have been through it, that can help you plan ahead and make some of those decisions, because it's absolutely right. Unless you want to eat ramen the rest of your life, you're going to have to figure some things out.
Right. Okay, thanks.
And on that note too, that is, women don't have to change their routines very much, because that's a lot of times what's going, they're already doing those things. But we're trying to get a men's coffee group going. And it's not just men with Parkinson's, but also men as caregivers. It's just a men's coffee group. It's kind of an informal group to sit down and go, hey, does your wife do this? Or, hey, did your doctor tell you this? And so keep an eye on our calendar. Tomorrow is the next one at 10 a.m. at the PRC. I know that's a little ways away for our outlying sites to get to. But just having a coffee time and sharing, if you can't get to a formalized support group. I know that the questions that come up you're not the only one that has that question. So if there's a few of you together, but keep an eye on our calendar, because we're probably going to change the time on that, just because it hasn't seemed to work for a lot of people. So keep an eye out for that. Moses Lake.
There's 6 of us here today, Cindy.
Hello there.
I had more of an observation than a question, but for my wife, who's had Parkinson's was almost 40 years now. And she's either in a wheelchair or walker. One of the things we found, suggested by In-Home Medical, was a smart bar. It's a grab bar, sort of a bed rail that mounts in between the mattresses, which has really been a great thing for us.
Baby born.
Baby born.
Whoa.
At ours or yours.
Is that here?
I think it's here.
I think we're, yeah, okay.
Yeah.
Wow. Well, that's assisted. We have a bedside commode, and it allows her to get out. She's trying to employ the rolling, but there's times when you aren't moving, and what that bed, smart rail it's called, provides for me is sleep. I maybe wake up, I don't have to get up, which is really a big deal, and allows her to basically get up, stabilize herself, can transfer, and get back in. And it was an $80 investment that's been, and we can pull it out, take it with us. We have a mountain cabin, and we just take it with us. And it's, I thought it might be worth mentioning as an assistant and as an aid for others.
Absolutely, and that's actually one that we've recommended to a fair number of patients just because of the portability that you mentioned, and the assist that really you can get from just slapping something between those two mattresses and putting a rail on it. So that's an excellent one. There are many other options out there for assistive devices, and so absolutely, that's another great question. If you do go in for some, therapy services, whether those be physical therapy or occupational therapy, ask about those, because a lot of times by doing something that simple, it allows a lot more independence, just like you're speaking of, where the patient is able to do those things without physical assist, and I know all of us want to be as independent as possible. That's really what we want, and so that allows us to be able to do some of the things that otherwise might be more difficult without having that. So excellent point. Thank you for bringing that up.
I got one other question, Cindy, or comment. It's for my wife, where she's got some definite on-off periods. To the extent possible, I try to counsel her to get ready for bed, do the best you can, and maximize your moving time. And really encouraging people to do that rather than sitting there when you're moving and then deciding to go to bed when you're not. It really takes a lot of the taxing component out of caregiving. So I'll just throw that in. And the other thing about the gentleman from Miles City, there's an advantage to guys taking over the role. You can get the food you want, and being Norwegian, I get a lot more potatoes that way.
So you really can eat ramen every day if you want to, yeah.
Or pickled herring.
Well, and I was going to say, I think I just heard you give permission to put on your pajamas way earlier in the day than we normally do, huh? So I'm going to take your advice and put my pajamas on when I get home. When I'm still moving. And thank you very much, Moses Lake. The next one I have checked in on my list is Pullman. And Richland, I know we were having a little bit of trouble with our connection. I don't know if you can do it with your audio line, but Richland?
Cindy, it's Tammy at Telehealth. They listened to the program, but then they hung up.
Okay.
But they were there for the whole program.
Yep, so they got to hear it. They didn't get to see it. So we'll send a copy of the DVD, which, by the way, we have a copy of this on DVD for any of the sites, as per with all of our other monthly DVD presentations. So if something happens and you need to leave or you miss out on a presentation or somebody can't make it, let me know. We'll make a copy and we'll get it out to you. And we're like a week away from having the last 12 of them edited on YouTube so that you can watch them. So it's when you harness the energy of a 17, 18-year-old, the things that you can do. Thank you, Tammy. Tenasket, North Valley Hospital.
I didn't make the check-in, but I hear there's just one person.
Okay.
But it was a well presented, and I really admire the gentleman in Moses Lake. I'm sure we need to admire everybody, but he had some good hints. Thank you.
Thank you very much. Thank you for being there. Walla Walla.
We're here, two of us.
Welcome.
And I'm a caregiver, and it was a good program for me.
Thank you for being there today. Did I miss anybody? On our outlying sites, did I miss anybody? How about questions here in Spokane? Okay. Yeah.
Well, I guess I need this. Yes. Thank you. I wonder if you have any hints for short caregivers who have very tall patients. My husband is, well, he is about 6 feet now. He was about 6'3" and has very long legs. And I am 5'2".
Well, I'll start, and then I'll see if Melissa has anything that she wants to add, and I imagine that she will. I'm 6 foot, so I don't typically have that problem. However, with a patient that is taller, we have longer bones, we have longer lever arms, and so the positioning is going to be really key. So if you don't set things up first, and this is either if you're physically assisting or if you're just giving cues on how to set up appropriately, that longer lever arm makes it so much more difficult to accomplish the task. So if we're a little bit more compact, it's much easier for us to get our weight where it needs to be. Versus if we're tall, it takes a lot more movement on our part to get that chest forward over the feet and those kinds of things to be able to get up.
That's not too hard during the up times, but it's during the down times when patients are not quite that capable of thinking things through, so may not take the cues as easily. Or the other difficult condition is on toilet seats, which even though we have a tall one, isn't tall for a really tall person.
Yeah, absolutely. Yeah. So again, I'll mention one other thing, and then I'm going to let Melissa talk to and see if she has anything beyond that. That's where some of those tactile cues that Melissa was demonstrating can become helpful. So for instance, the giving that cue at the shoulder blades. When I was in that chair and she was applying that cue, I had no choice but to come forward. And she wasn't pulling hard. It was just the direction and the way that she was applying that just automatically lifts me off my bottom and moves me forward. So some of it is learning those key points of contact to be able to apply that so that you're not having a tug of war. Because, yeah, certainly during an off time, things become much more difficult.
Here you go.
Have anything?
Yeah, specifically with decreasing that lever arm would be...
Should I turn it off?
Lying on your back. When he's lying on his back, I should say, and trying to roll, that'd be a perfect time when you want to have those knees bent up. And if he's having a hard time taking verbal cues and processing a verbal cue, putting a hand just underneath the knee and just giving a little bit of pressure straight up, likely he'll be able to kind of follow that cue and then get his knees bent, so that you have less of a lever arm to worry about turning and such. And then also going from on his side to sitting, keeping his knees tucked pretty tight to his chest if he can, so that going from that lying down position to a seated position is again in a shortened lever arm position, so that there's not quite as much length to accommodate. Secondarily, probably sit to stand. You might have to play with positions for you, because I was kind of going over Caleb's back for that position. So for you, it might be coming to his shoulder blades from under his arms rather than over his shoulders and going in that position. It is more tempting to lift in that position, but if you're really, if you're shorter than him, you're not going to be able to bring him to standing from overhead. So going under the armpits, but still focusing on getting to the shoulder blade or the ribs rather than on the actual lever of the arm. Does that help?